you. Thank you. So good afternoon, everyone. I'm Dr. Arjun D. So today we will talk about ethics and end-of-life care. So ethical issues are very common in our day-to-day practice, irrespective of the specialty or whichever field you're working. So let's start with the visualization of a transition of a chronic illnesses. So this, in the early phase, you could see the early phase, then the disease goes in a containment stage where the patient will be able to maintain his functions. Then the decompensation, where the patient will start experiencing life-limiting illness issues, and thereafter he will go into dependency, and the symptoms will increase and going to decline and become terminal, and death and bereavement. So as you notice, palliative care starts right after the diagnosis. So when it comes to ethics, we have 4 cardinal principles to consider. Those are autonomy. Autonomy means the patient has the right to take the decision. The decision of the patient is final. Beneficence, which basically means do good, only do good for the patient. Non-maleficence, try not to do any harm. And justice. Think about the 4 cardinal principles that all these have equal weighting in an ethical issue. So when you are trying to manage an issue, in ethical ethical issue, all these cardinal principles should have an equal importance. When a patient becomes near end of life, these things should be considered. This should be there when we are managing a patient. One is the respect for life, which of course should be there for every person you are seeing. But in addition to that, there should be an acceptance of inevitability of death while seeing a patient who is nearing his end of life. So in case you are taking a decision for him or her, some things that you need to consider are the potential benefit of a treatment that you plan to do for him should be always weighed against a potential risk and burden the same procedure or treatment that could have on the patient. Our aim is always to preserve the life, but if the burden of the life-sustaining treatment or a procedure always outweighs the benefits, like whatever we are planning to do is will help him, but the burden of life-sustaining of that procedure will have less benefits considering his condition. We will have to think twice about that. So end of the day, our aim should be to make him as comfortable as possible. And all decisions we are taking, we will have to consider the individual needs and must weigh against the needs of the society. So have you ever thought of your own death? And how do you like it to be? Anyone ever had a chance to think about your own death?
We would like some response here, like Have you, any one of you, ever thought about your own death? Ever tried to picture that? Think about it, had the situation to think about it. Can we have at least one response?
Well, in that regards, I want to put my opinion that nobody exactly thinks about their own death exactly. But whenever we come across certain patient who was nearing to death, at that time we can correlate to that situation. Okay, if I would be having this kind of situation, what I will face. So that kind of situation I will, because simply nobody will sit on a chair and he or she will think that how will I going to die, isn't it? Nobody will do like that act. But yeah, when that particular person comes in a contact with the patient who is near to die or dying situation, so we feel okay, this much of pain will be there when we will be dying. I think so.
Okay, thank you, sir. So another response came of a painless death with loved ones nearby. Not thought of it seriously. Okay, good. So, so which one of the two which I am going to show you, do you think is a better way to go? See, the first one is an old lady. You could see her. She is in end of life with her family, and her son is feeding her water. Another one is tied up a numerous number of tubes in an ICU ward. Okay, so everyone chooses one. Yes, as yes, thank you for the response. And as everyone mentioned, everyone would be preferring a painless death with their loved ones nearby. The second, we are living. Okay, at the time of death, we need to be conscious and with good thoughts. Okay, thank you, Nirosha ji. So here, let me start with the case. So we have a 72-year-old woman with a carcinoma lung, which is in a very end. She's terminally ill with hypertension and diabetes. She's cachectic, bedbound, and dependent on all activities of daily living on her family members or a caregiver. She was brought to you with reduced oral intake. She is already diagnosed with an aspiration pneumonia and end-stage renal disease. So the advice was for antibiotics and dialysis. The physician has seen her and advised her, but the patient refuses. She is oriented, while the son wants her to undergo dialysis and a rice tube insertion. So the question is, what will you do? Will you advise the patient and cause her to have an NG tube, antibiotics, and dialysis? So this is a situation where you could use four cardinal principles. So let me repeat the question. Will you advise the patient and cause her to have a nasogastric tube or antibiotics and dialysis?
Any responses?
Okay, let's go to the next question. Will you avoid talking and discuss the treatment with the relatives alone? Technology has said without patient's willingness, they cannot use. Yes, okay. Okay, so Pratibha ji has applied the cardinal principle of autonomy. The patient has said she doesn't want to go for a rice tube or any other interventions. So next question is, will you avoid talking and discussing the treatment with relatives alone? Will you respect the patient's wishes? Will you refer her to a higher center? Or always with the patient? Okay, good. Respect the patient's opinion. Okay, we will come to this question later. So when it comes to the primary objective of our end-of-life care, as ICMR says, is to mitigate suffering. It is to cure sometimes, live often, and comfort always. There is no exception for this rule. So our aim is always to mitigate the suffering, reduce the suffering, make the patient comfortable as much as possible. So coming back to the clinical decision making, we will discuss about autonomy. So who takes the decision? In patient management, so the decision is usually made by, even though the patient finally has a decision, we have a role. The doctors, the clinical team, the family, everyone has a role, and the decisions has to be taken with considering the socio-cultural context, and of course, it should be taken with identifying the expectation of the family and the patient and the family. So it's not always up to patient us. So the expectation should also be always inquired about. So one thing that we have to think before involving the patient is, does the patient have a decision-making capacity? So the question arises is he able to understand this current situation? Is he able to appreciate the choices that are available? So if we are planning to give multiple options for treatment, is the patient able to appreciate each of the choices? And is he able to reason the benefits and burden of the treatment? Like, could they make a rational decision out of it? And are they able to make their goals and their expectations to us? So that these questions should be answered if you're when we depend on the patient's decision. So this may vary from patient to patient, the situation case to case. Always respect. We should have a respect for the patient's privacy and confidentiality. The patient has to make a trust on us. So this is a relationship with the patient that we make, the clinical team make. There should be always an empathetic truth telling. You should be empathetic, but you should always say truth. Only truth should be conveyed to the patient. There is no option for a lie, whatever the reason was, and all choices should be informed to them. Whatever choices are available should be informed to them irrespective of circumstances, and sufficient information has to be passed on to them. And when we are making a decision, it should be shared one with considering the patient's cultural and religious beliefs. So what happens in other countries, so foreign countries, what happens is the patient has an autonomy. But coming to our country, we have a collective autonomy where the decision is usually made along our family members also. So yes, as I mentioned here in the picture, the doctor is giving him multiple options, but the patient stand confused with them. So every informed consent should have the patient should be explained all the choices clearly, where he's able to make a decision. So when it comes to expert, I may be an expert on healthcare, but the patient, I am the expert on myself and my life. Where we as an expert doesn't have a choice, the patient is more expert on himself and his life. So he is the one who makes a final decision. As patient autonomy is to be upheld at all costs in medical ethics. So one thing I want to warn you is that because the patient asks you to do, you are not compelled to do anything. Like a patient who wants to do a procedure which you believe you will not benefit him, you are not compelled to do that. Just because a patient asks, that doesn't mean you have to follow it. So here, suppose a patient has dementia and has lacks the capacity to take decision for herself. Then what will you do? That is when we can make a surrogate decision maker. Usually the surrogate decision maker is a next of kin, wife or a brother. Yes, living will, like a wife, siblings, children, or there could be nominated persons, or it could be a legally on a reasonable person who's like a guardian. Thing you have to ensure is that whoever is the surrogate decision maker should have the best interest for the patient. Also, we have to look for advanced directives. Is there a living will, or has he given a medical power of attorney to someone? So when a patient autonomy, like in this case, a patient autonomy is compromised, beneficence is the guiding ethic. So what is beneficence? Beneficence means do good. So it's determining the best interest for the patient. So here, the earlier one was a relationship, our relationship with the patient, but here it's a relationship with the outcome. So we all have an obligation to act in the best interest of the patient. So this question should come to our mind when you're dealing with such a case. Every person, any ethical decision-making case, like, am I fixing what is wrong? Am I effectively managing the disease process? What is the burden versus benefit of the treatment being offered? So I'm planning to start him on a new medication. Is it going to add to his burden or is it going to benefit? So what is the risk and how much?
Just 1 minute.
So what is the risk? Sorry. What is the risk? How much suffering and pain will the intervention cause? Am I simply delaying the inevitable? What is the expected prognosis with or without the treatment in terms of survival and disability? So here, we have a 20-year-old boy with metastatic osteosarcoma of the lower end of femur with lung mets and anemia. He has a large tumor on his thigh and insists on getting operated. Both parents and the patient is adamant on regarding the operation. What should the surgeon do? So he has a metastatic osteocarcinoma, very advanced disease with lung mets, and also there's anemia. And he insists on getting the largest tumor on the thigh to be removed surgically. And the patient and the family is adamant on the decision and they want the surgeon to remove the tumor. So here, our decision should be based on non-maleficence, like we do no harm. So this principle has a relationship with our actions. The aim is first do no harm, respect the sanctity of life. Here it's a right of the physician, like and where we can take the decision. We have a decision to even it helps. Usually, we have to override autonomy, because if they are asking for something which is not going to do harm, not going to do any help for them, but only harm. We as a trained medical person, we may be knowing that, but the patient is a common man, he may not be knowing that. So he will be asking for that because hearing from someone else that that drug will help him. So he asks us for that drug. But we may be aware that this drug may cause more burden to him. So we can always say no to that. So here, let's just weigh the boys, the 20-year-old osteosarcoma boys condition. So if we go for the surgery, what are the benefits we are having? So there is debulking, the mass will be, and they are expecting for a psychological relief. So they believe this removal can help him for long. So there is a psychological benefit and there is a debulking surgery. So the patient may have some symptom relief. So those are the benefits. But when it comes to the harm, so it's a major surgery. So he's going to be in pain. He will have to undergo general anesthesia. Then there is anemia. So when we are weighing that, the harm weighs more. So there we could use the principle of malefacence and we can inform them. So what happens usually is that we could explore why they are asking for this surgical intervention or any other procedure, because there would be usually some reason why they are asking for it. So if we find out what their issue is and we can help them that way, making them understand the benefits and harm, and we come to a decision. So this is something very important, doctrine of double effect. So it's a single act having two possible foreseen effects, one good and one harmful, and is not always morally prohibited if the harmful effect is not intended. So, so this is an important definition. Like if you're planning for an intervention to person, and we expect two outcomes from it, the intervention could have two effects. One would be good and one would be harmful. So we are totally aware of this both outcomes, but it's not morally prohibited if our harmful effect is not intended. We are expecting the good effect to happen, not the harmful effect, but we are aware that harmful effect is going to happen, but we outweigh the benefit outweighs for the action to happen, then it can be morally happen. It could happen. So the thing said is the action should be morally good. You must not decide for the negative effect. The good effect must be as immediate as the negative effect. So, for example, when it comes to like a ectopic pregnancy, a lady comes with an ectopic pregnancy in fallopian tubes, and the surgeon, if the surgeon performs a salpingectomy. So here, salpingectomy is yes, it has harmful effects, but the aim, we know the harmful effect, but our aim was to save a life. So a good effect is intended for, and we are aware of the harmful, but the good was more weightage. So we prefer to go with the surgical intervention. So this is the situation of where doctrine of double effect is happening. Also, another situation that we could always use is a person with an in an end of life coming with very refractory breathlessness. We could administer midazolam for him. That will help reduce his suffering. But when we look into that, the midazolam has two effects. It also has a respiratory depressive effect, and at the same time, it will help calm him down and decrease his suffering. So we know both outcomes, one good and bad, but we are looking into make the patient who is nearing his end of life to be comfortable. So this situation could also be used here. So we have a 57-year-old male with advanced metastatic cancer of the lung. So he is severely breathless due to progressive disease. All reversible causes of dyspnea has been ruled out. So we cannot correct them. And he is there waiting for getting admitted into the intensive care unit for artificial ventilation. So what do you think about the decision? So it's a 50-year-old advanced metastatic cancer of lung, with a severe breathlessness with a non-correctable condition. There is no correctable causes. It is purely due to the progressive disease, and they are waiting for an artificial ventilation. Is this decision justifiable? Do we think we should admit this patient in an intensive care unit? Should we intubate him? Should we restate him if he has arrest? So please put in your inputs. So do we think you should admit this patient in ICU? Should we intubate him? Should we restate him if he arrests? So here is one more cardinal principle that we have to think about in this situation. So as everyone of you know, healthcare is a scarce resource, and equitable access to resource is not possible in our current situation. And here the question is, are we allocating the precious resource of ICU to justify? Are we considering the family resources? So he is a end stage, he's having end stage lung cancer who doesn't have any correctable cases of correctable situation of breathlessness. So is there any use in ventilating him or intubating him and putting him on a ventilator? Will that benefit him? No. So the answer would be no. At the same time, are we allocating this precious resource of ICU justifiable? There could be someone else who has a correctable issue, who just recently had a that most commonly a COVID-induced pneumonia. He needs an intensive care. So he has a correctable condition where he may benefit from this putting into a ventilator. At the same time, we have another person who may not be, who will not benefit from this intervention. So which one will be justifiable? Of course, the correctable case will be justifiable. And are we considering the family resource? So are they able to afford for a ICU ventilation for the period of time he is going to be there? So as many studies occur, says we have healthcare costs put many families into debt. So are we considering the family resources? So end of life care consumes 10 to 12% of all healthcare facilities. So it's our duty for an individual person and the society as a whole, which may conflict cases which is limited resources are disproportionately consumed by critically individual. We also assessing the futility then becomes imperative. So what's futility? It's an aggressive medical intervention in terms of effort required and financial resources utilized, having little or no clinical outcomes. So we are trying to prevent the dying The hard facts that we have to know is that they does not slow the disease progression. They will not sustain his life. They will not reduce the disability and will not improve the health or discomfort of the patient and the family is going to suffer from. So are these beneficial? The treatment that does not provide net benefit for the patient may ethically and legally be withdrawn or withheld. The goal of medicine should shift from palliation to the palliation of symptoms. There is no ethical difference between withholding and withdrawing. So to mention euthanasia, euthanasia is an intentional act of ending a patient's life by medical means at the request of patient or family with an objective to end or avoid suffering. So a few years ago, the Supreme Court of India passed a ruling that passive euthanasia in India is legal, but not active. But I don't know, euthanasia is not a passive, it's a deliberate event where we are actively involving them. Hence, it's illegal in India. But let me remind you, withholding and withdrawing life support in a patient with terminal illness nearing end of life is not euthanasia. So we are regarding the recent Supreme Court judgments. The right to die with dignity is a fundamental right, as already declared by the constitutional bed judgment of the court. So we declare that an adult human being having mental capacity to take an informed decision has the right to refuse medical treatment, including withdrawal from life-saving devices. An adult human being of conscious mind is fully entitled to refuse medical treatment or to decide not to take medical treatment and may decide to embrace the death in a natural way. Mentioning about the advanced medical directive or living will, it's an individual's advanced exercise of his autonomy on the subject of extent of medical intervention that he wishes to allow upon his body at a future date, which he may not be in a position to specify his wishes. The purpose and object of advanced medical directive is to express the choice of a person regarding medical treatment in an event when he loses the capacity to take a decision. Living will is a legal document which could be created by the patient, explaining and documenting their wishes about medical treatment if they become incompetent or unable to communicate due to terminal illness. Actually, it's also a guide to us, medical professionals who and family, about this medical care when a situation arises that he is not able to make a decision for himself. So this is okay. So the clinical integrity, there is always dignity for the patients and profession. Truthfulness and honesty should always be exhibited in every person to every case scenario, and informed consent and truth telling should be frontline. Always communicate what you have document and what you document what you communicate. Tell them that you are documenting this and always document whatever you have done to them or what they express to you. Thank you.
Thank you, Dr. Arjun, for that comprehensive session. Now the forum is open for feedbacks, queries, or discussion of points regarding this particular session. Anything? Yes, sir.
Yeah, ma'am. My question is for sir regarding this living will. So as I never come across such kind of legal matters. As a nurse, we are not supposed to enter in such kind of legal matter. But as palliative care is totally different to the such as nursing care, general nursing care. Palliative care is totally different. So yeah, but how can we deal with this will and all these kind of legal acts with the patient? Because ultimately, it is a patient choice only to whom to give the property and all, or what kind of, how can we deal actually? Because as such, I didn't face any kind of this will kind of issues to the patient.
You may usually see them. Okay, when one of the things that we use, so you know about collision. So those patients will have. So one of the reasons that we say why collision should be broken is that to have a living will. Most of us would like to make a living will for what we need to decide what's happening afterward, not only to our body but also to our, yes, as you mentioned, our belongings. So when you identify a patient who is nearing end of life, of course, we can talk them the option about making of a living will, so that they will be able to take the decision even after they on themselves, even after a condition, even if they reach a situation where they may not be able to take a decision for themselves.
Okay. But actually, the time is very crucial to discuss such kind of events or topics. So actually, it is quite difficult task to when patient is dying and we are talking about this will and all. So it sometimes create hurdles.
Yes, sir. But this is something that's very inevitable, and that's not just for us. That is going to benefit the patient. So there is no wrong in conveying that to them. It's there. Finally, it's up to them whether they should take a decision on that. So we could always say to that, like, so what happens in my practice, I have usually see when a patient comes to me with a diagnosis and end-stage cancer, I would try to once and I not just in the first visit, but once I have made a rapport with them, I will give a suggestion for their advanced care planning. So, what do you like to do? Will you, if you get condition like this, so if you are going to blood test, you need do you would you like to get into ventilator support, or would you like to be admitted in a palliative care center where we could help you with your symptoms and make you comfortable as long as possible? Also, I will also tell them that yes, I know you have an advanced condition, so you may go into a terminal stage as soon. It may be prolonged. It may happen anytime, but it's better to be prepared, and it's better to have a living will for you. So it can be communicated. It's for them. It's for their benefit. So there is nothing wrong in convincing them. But I wouldn't open it bluntly the first session itself. It will take some time, or the second or third visit. After I have maintained a good rapport with them, I would definitely advise them on that.
Thank you, sir.
Thank you, sir.
Any other queries, comments, feedbacks, inputs? I would humbly request everyone to switch on their videos if possible, so that at least the last 5-10 minutes which we are going to have as part of the session becomes livelier, not just the black boxes we see. Thank you, thank you. Videos are coming on. Thank you so much for that. So any other points related to this particular session, because Dr. Arjun is having an important call of duty. Patient is waiting for him. So in case you are not having any feedbacks pertaining to this particular session, with your permission, I will relieve Dr. Arjun from the session, and then we can continue with our general feedback. I hope everyone is okay with that. So, Dr. Arjun, thank you so much for giving your time for this particular cohort. And yes, now I will take it on from here. Thank you so much for joining us. See you soon.
Thank you all. It was,
Others,
I was
please
very
stay
fortunate to
connected.
meet you all. Sorry. I
Thank
was
you,
very
sir.
fortunate. Thank you very much. And I was very fortunate to meet you all and hope we could all meet once and at least once working together and palliative care. Have a good day, everyone. Thank you. Thank you very much.
Thank you so much.
Thank you.
So that was the end of our official sessions on foundation course in palliative nursing. Now, going back to the general feedback. Of course, you might be like little bit confused why Sripriya is sitting here when the all other sessions were being coordinated by Senior, whom you have been interacting with a lot, I believe. So this is an open platform wherein I do understand that from our point of view, from Pallium India's Tips Echo point of view, we had been facing some difficulties like in getting the case presentations. Of course, the people who are sitting here, you all might have given the case presentations earlier itself, but then we had some difficulties, and then always this a little bit of lack of interaction was always there. But today I'm so happy that I'm seeing the screens full. Thank you so much for that. And now we want to hear from you what could have been better in this course and what was good in this course. So we really would like to hear some of your feedback so that we can improve for the coming cohorts. Any volunteers to start the discussion, please?
Thank you so much for the opportunity that you have given it to us. I think all the sessions were very, very good and very, very useful to us. Thank you for all of that. And we are really sorry about the case presentation, and that I think we were not able to have enough case presentation. And then I was just thinking maybe in the future, if we are, when I was preparing for my case presentation, I prepared it myself, even the discussion point based on the previous class that we had. And I was thinking but I presented it on the day of on the day when we are talking about pain. So if I knew that my case presentation is going to be based on pain, I could have prepared myself a little better than that. And so in the beginning, if we are all being told that your case presentation will be on this particular day, and prepare your case also based on this, that would have been very good. And I think maybe for some of us, we might be even able to do 2 or 3 case presentation also in that case, if the participants are less. Apart from that, I think all the classes were very, very useful, and we learned a lot. Thank you so much. And we are sorry, but sometimes because of the poor internet connection, if we put on the video, the network connection had become very, very bad. So, and we are sorry for that as well.
Never say sorry, ma'am. Yes, regarding the informing the participants priorly regarding the topic they need to take up for case presentations, it is noted very well, and we will ensure that that communication goes clearly from our end in the future cohorts. Thank you for that valuable feedback. And yes, we do understand that network connectivity issues always were there. So anyways, thank you so much. Thank you for so much for those honest feedbacks. Anyone else?
Yes, ma'am.
Yes, sir.
Hello,
Please.
everyone. Yeah, it was a great experience, learning experience, I would say, from the day one. Mr. Raj Gopal sir, introduced all of you, and give advice to all of us for starting this program. And it is the last day. We don't believe actually how the time has been gone. So when I received, this is my true experience, or feedback, that when I received the timetable, still I have that timetable is in my hand. I thought, how 3 months will be there. Every Monday I have to. How would I? It will be lengthy process. But to be very honest, once the program is started, how these 3 month 18 sessions are finished, I don't remember how it exactly, it finished. Rather, I, missed 1 or 2 lectures because of my busy schedule. So I just missed only 2 scheduled. Rest of the sessions I have attended, but it was too fast, you know. So I would suggest, madam, so just if possible, expand certain topics. I rather say, we all have, time limit, because I work also for certain events. So I, do respect that time is a crucial part of any event. So we have to prepare or execute all the things in, certain period of, frame of time. But if possible, certain topic requires still more time to be executed, I would say, madam. The specific topic regarding pallium, this palliative care,
Okay.
particularly this pain management and all. We all, do this pain management practices in all our general nursing practices day-to-day life, I would say. But when it comes to the palliative care or palliative pain management, I think we require certain more, time to be understand the exact, the intensity of pain or management of pain. Because many a times, we do believe or we do face certain patient where pain management is the crucial part. Patient is not asking for the cure sometimes. They don't want to cure the disease. First of all, they are, asking for to treat the pain first. That is the most important thing. So this is my humble suggestion.
Sure, sir. Like a very valid suggestion as well. So you would like to inculcate more topics on the real pain, difficult pain management, and want to include more sessions on that in the nursing course in coming days. Noted, very valid point, sir. And of course, we will be ensuring that this reaches the eminent faculty panel, and necessary changes would be taken care of in the future cohorts. Thank you so much. Any other feedbacks? I can see a group of people sitting there from one device. At least one of them, if could, logged in with the name Samir. Meanwhile, they are preparing. I believe that we should never leave the voices of Nirosha ma'am unheard, because she, I believe, is the only one participant from international location who joined us for this cohort, if I believe I'm correct. Nirosha ma'am.
Yeah, actually, I must give my respect and gratitude to take part in me as a participant for this program. Actually, I must thank giving this opportunity to improve my skills, knowledge, and as well as practice, because in Sri Lanka there's no established palliative care program for nurses. I mean training program. Actually, I that is not true. In a way, I am happy with this pandemic. This sort of online platform is open for us. I think that is one of the advantage of pandemic, but the harm is much more. In a way, this is beneficial for us. Otherwise, I won't be able to get this opportunity to update my knowledge. So I must thank you all to organizing and take part in me as a student for this course. And I must say that I have improved a lot, and with several aspects in palliative care. Some of the topics I have never come across in the current in the actual clinical practice. And I would like to give one more suggestion on case presentations. Actually, case presentation is a very important and very helpful to update and apply our knowledge into practice in a way. So including me, I think for most of the case presentations have done on pain management, if I am correct. 3 or 4. Other case presentations are very few. The topics are very few. Rest of the topics. So I think it will be better if you can ask the participants to tell what is the topic you are going to present. Then accordingly, we can decide our topic based, including other topics as well. Otherwise, all the participants will stuck on the same topic. That is only my suggestion. I think you can think of that, whether it will be work or not.
Yes, definitely, ma'am. That is a very good suggestion. Like, instead of waiting for everyone to, yes, of course, when you are into the nursing field, the more patients you come across would be all based on the pain management side only. And that is why we receive most of the case presentations focusing on pain management only. Yes, definitely, maybe we could, as Nirosha ma'am said, we could try like giving the topics to them and then asking to bring in the case presentations based on that particular topic. Yes, of course, that feedback is also taken. Somebody else would like to contribute their feedbacks, inputs? Anyone else? If no one is like you if someone is reluctant to share your open feedbacks now, you are always free to mail to us your points, your valuable feedbacks, suggestions, uh, opinions for improvement through email. Also, you can mail to us in the mail ID tipsecho@palliumindia.org. Talking personally, of course, nurses have always been vision of like patience for me, because whenever myself or my family members are being admitted in hospital, whether it be any case, it is the nurses whom I see the most, other than the doctors. The doctor comes only once or twice a day, and apart from that, it is the nursing professionals who take care of us so much. And it has always been a pleasure interacting with you people, because you found out time to listen to us in the first place for this course, for these 18 sessions. And that was a very good, and we believe that this is going to be the start of an incredible journey wherein you can spread the pain-free emotions to other people around you, which whatever little we could give you as a knowledge of palliative care we had given. And we wish that you spread across this knowledge to everyone around you, making people pain free, making their lives dignified in ways you could. So that is our prayer for you. And of course, even though the sessions end here, we will be keeping the WhatsApp groups live. So whenever you are facing any, queries related to any of the real life patients you are handling, you want any suggestions, you want any guidance, you are always free to connect with us. We will be sharing our numbers of a free telehealth consultation in the group. You can save that number, and whenever you are in doubt, you can definitely get in touch with that number. We have a separate helpline for handling stress. We will be sharing that as well. So please do stay connected in the WhatsApp group and be active. Keep checking for the updates. The new courses being launched will also be updated in the WhatsApp group. So I believe that this end of this session is the beginning of another successful journey in the field of palliative care for everyone out there. If no one has anything else to say, shall we wind up?
Thank you so much, ma'am.
Thank you so much. It was nice interacting with every one of you. And from the Tips Echo team of Thalem India, this is Shripriya signing off. Stay connected, stay safe, be happy. Bye-bye.
Thank you. Thank you.
Thank you so much.